What the heck is direct primary care or direct care, actually, since there are other specialties that are trying this practice model other than primary care? It's a subscription service, basically, that gives your patients access to you 24/7, and it's disruptive sometimes. So we talked to Dr. Maryal Concepcion, who is the host of My DPC Story, where she interviews physicians on their direct care journey. So we talk about her practice, her podcast, why she chose to stop billing insurance company and give her patients access to her 24/7. We also talk about what happens when patients abuse this service, why patients tend not to do that, which patients tend to be interested in this model, and why earlier that day, a weekday, she wasn't even in the office. Dr. Concepcion went to Creighton Med School, completed her Velley Family Medicine residency in Modesto, California, and then moved to rural Northern California. She started working in the corporate model before starting her direct primary care practice, for which she is clearly an evangelist.
Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. And now, here's Dr. Bradley Block.
And now a word from this week's sponsor, Laurel Road.
Buying a home like the one I grew up in has been my dream. We had this great yard where my brother and I would run under the sprinklers. We had a big kitchen table where I told my parents I got into med school. Now I'm a member of Laurel Road for Doctors, where I got a great rate on a physician mortgage and was eligible for no money down and no PMI, so I could make new memories in my own home.
Laurel Road for Doctors. Banking, insights, and benefits uniquely designed for doctors. See laurelroad.com/doctorhome for full terms and conditions. Laurel Road is a brand of KeyBank NA and equal housing lender. NMLS 399797.
Dr. Maryal Concepcion, thanks so much for coming on the podcast.
Thank you so much, Brad, for having me today. This is super exciting.
So we're talking about direct primary care.
Mm-hmm.
So that means, well, what does that mean? Let's start with that. What is direct primary care? What is direct primary care as opposed to like concierge medicine, as opposed to just not taking insurance? Like what do these things mean?
Yeah. So I absolutely love this question. And I think it's super appropriate to start with this, especially for an audience of physicians on your podcast and on your YouTube channel who might not be familiar with the terminology. A lot of people assume that direct primary care or DPC is concierge medicine. And where the line in the sand is drawn, so to speak, is that a typical concierge practice will take insurance while charging a patient, typically a very high fee for concierge style services. So being able to text, call your doctor is in concierge medicine most of the time, but you are still being billed and limited to what insurance says, you have covered or not. But typically in practices where a person is a direct primary care physician, a direct primary care physician typically will offer concierge style services. So for example, in my own practice, patients can text, call, leave me a message directly in the portal that goes directly to me and not an administrative assistant. And yet the average price per member per month for all Americans is on average $75 to $100 per member per month. There are some practices that charge children as little as $10 a month for concierge level services without saying, yes, I'm going to charge you your fee plus, then I'm going to bill your visit to your insurance company. And then you might have to pay the premiums or not the premiums, but you might have to pay for your visit through an insurance bill plus the doctor's fee on top of that. So that's how I like to describe the difference between concierge typical practices and direct primary care.
Okay. I think I got that. And so what made you decide to leave typical medical practice and start direct primary care?
Yeah, that's a great question. So I went from being trained at Creighton University in a rural setting. I did most of my family medicine rotations, and that was in Superior, Nebraska. It's a town of 2,000 people that serves about a 6,000 people radius in the middle of the geographic United States. And there I saw the power of being a family physician, being a generational family physician, somebody who knew, kids all the way until they were adults, all the way until they were delivering their own, or all the way until they were having their own grandkids join the world. And so I loved that. And I only sought out rural locations to practice family medicine after residency. My husband, who's also a family medicine physician, we had heard early on about this idea of job share, and we're like, what is job share? That's amazing. And so we had this dream of having a family and being able to be home with our kids and not having to be 100% at a job and have to employ, a nanny or an au pair, while being able to practice in a rural position, because he also trained in Superior, Nebraska. And so that culminated in us finding a job that we thought was our dream
Wait,
job in
sorry,
rural. Go ahead.
job share.
Yeah,
It sounds like two people together are one full-time one FTE, one full-time
correct.
employee or one.
Yep.
So, okay.
Yeah, that's it exactly. And so, a little backstory. There was a lovely obstetrician who we worked with at one of our rotations in OB, and we asked him one day. We're like, "Oh yeah, how old are your kids?" And he's like, "I think 26, but they live in Chicago, and I don't live with them, so I don't actually remember." And that was one of the, impressionable moments where we're like, we want to have a family, but we want to be able to be there with our kids. So job share, correct, is a job that is shared by two people to make one equivalent worker, one FTE. And so when we moved to Northern California, we both did residency at the same location. We chose to pursue a job in rural Northern California where we were able to do full scope care. That was what we thought was our dream job. And then after the golden handcuffs of here's your bonus sign on and here is your salary, then it was, okay, so now we're going to go to RVUs. And we had to negotiate fairness of RVUs. For example, our RVU rates were being calculated at a 2017, 2018 rate, even though it was no longer 2017, 2018. And we had to fight to prove that. And the battle of being paid fairly while still being able to protect the time that we had with patients to maintain the quality we had with patients was just continuously, it was in a continuous battle in terms of like how we felt the situation was going. So it was September of 2020 when I was 28 weeks pregnant with our second child, and negotiations pretty much stopped because there was a turnaround of admins at the company we worked for. And we basically both got a letter that said, well, you can either consider yourselves terminated unless you sign the RVU contract that we determine is appropriate. And so knowing this history of inappropriate contracts and inappropriate RVU compensation, in my opinion, we were given this letter of you're going to be fired or else. And I said, well, thanks, but no thanks. I can't be enslaved to take care of my patients based on how an admin, dictates is appropriate. And
No.
yeah,
No.
yeah,
Maryal, if you really cared about your patients, then you would take whatever they give you, right?
that's
I'm
unfortunately,
kidding.
that's unfortunately
But that's what
the
they sell you, and
feel.
that's what that's what they make you feel.
Mhm.
That's how they
Yep.
make you feel.
Yeah. And it's
And they're just gonna
so.
pocket the difference. Yeah.
Yeah. And well, and that happened at, the strategies of, yes, CMS is going to increase your RVU rate for family medicine. However, of that increase rate, we're only going to give you X%. So, the things that we didn't learn in medical school are this idea that, we are givers who go into medicine in general. Like we put our lives towards careers where we're taking care of other people. And yet too often, especially in primary care, we're made to feel like we're the bad people. And so with that feeling of like, you literally just gave me a sign this or be fired letter, and I'm 28 weeks pregnant, I'm going to lose healthcare insurance for my child. Oh, heck no. And so at that point, I was very thankful that an orthopedic surgeon 2 years prior had told me about direct primary care. I'd gone to conferences to learn about direct primary care, but I really
Wait,
hadn't.
an orthopedic surgeon taught a primary care
Yeah.
physician about primary care.
Yeah,
That
because
would be
that
the
orthopedic
last
surgeon,
specialty.
I know. Yeah. But it's like just how, because you work in the emergency room, like I heard on a recent recording, you see 28 to 38 patients on one of your shifts. And it's like, no matter who you are as a physician in emergency medicine, dermatology, it doesn't matter. Orthopedic surgeon is just another example of this, that the devaluation of physicians and the ability for us to be able to take care of our patients appropriately and needing the time to do that has become so bastardized in our healthcare system. And so an orthopedic surgeon, yes, Dr. Ariana Demers, was the one who had said, you're super frustrated with the negotiations that you're experiencing. Why don't you read about direct primary care? And so, yes, she had told me about DPC about 2 years earlier, and she had left our local hospital system to open up her own private practice. So people are doing direct primary care as a business model in their own specialties left and right these days. But for me, when I was armed with the information of what is direct primary care, how powerful can it be, and arguably it can happen in and be successful in any community, that's rural, urban, doesn't matter. I basically had you either do DPC or you leave medicine moment. And so it was at that time that I chose to do direct primary care. So that's the long answer to your question of how did I choose DPC?
And then come on, I feel like the story's rolling. And then what happened?
Yeah. So it is. I mean, honestly, I am every single day, I tell as many people, that's patients as well as physicians included, about direct primary care, because the model, in my opinion, is really at the crux of how we change the quality and the accessibility and the availability of primary care, as well as, like I mentioned, specialists are choosing direct primary care all over as a business model all over the nation. This is really how we return healthcare to the people and give Americans the healthcare that every single human being deserves who happens to be physically in the United States of America. And so when I say that, again, I go back to people are paying $10 a month for their child to have access to their doctor. So for example, yeah, you have a rash. That stinks. Go ahead and text me a picture of that and we can see what we can do. And if I need to see you in person, then we'll do that. But in general, direct primary care is so powerful in terms of reaching, again, accessibility, availability, and affordability to all Americans, that I have this passion of continuing to share about direct primary care and highlight the physicians doing direct primary care as an everyday part of my life. And so in addition to seeing patients, I also host a podcast, and that's how, we connected. And my podcast, My DPC Story, is literally highlighting physicians all over the country who are doing direct primary care and how they're doing it. Because at the root of it, it's not only education about DPC, but it's also a set of, it's a series to give other physicians, no matter what specialty they're in, the tools to say, oh, look, they didn't go to business school either, but yet they own their own business and they're successful in rural, urban settings. It doesn't matter. Wow, I could do that too. And so for me, it's my own little contribution to the movement that has really changed the lives of so many Americans already, so many physicians' lives already, and it continues to grow like wildfire, which I'm super happy to see, but also I just feel like it's almost like it's so rewarding to my soul to see people making an impact in their communities and feeling that, wow, this is why I went to medical school, not because I needed, to work for a system where I saw too many patients in a day, but I really actually got to care for my patients. And so, this is going into the weeds a little bit, but like before we started recording, you asked like, oh, you're at the end of your workday. And technically, yes, I'm at the end of my workday, but I've seen 0 patients today. I've had messages virtually, but I've not seen any patients because my patients, in terms of that concierge style of care, but not at a concierge price, my patients are still able to message me directly and I get back to them, but I don't need to physically see them in person because I'm no longer working for the 992-1314-0405, whatever. I don't care about those anymore because my patients understand the value of affordability, accessibility, and availability, and they just message me directly. So I technically have been working, but I've taken care of my kid today, taken him to the doctor's appointment, taken a nap. Like I've done lots of things today. And I feel so much, I feel so good inside because I'm contributing to care locally as well as contributing to the movement of DPC nationally.
Oh yeah. I mean, I get it. I mean, I can't tell you how many patients that I see in a given day that I could have diagnosed them
Yep.
accurately and managed them over the phone
Hmm.
if they just told me their story. I could have saved them the trip. I could have saved now, but I can't do that because billing, I take insurance and
Hmm.
billing. I just can't do it. There's also the issue of the liability, right? Like, let's say you're wrong. And but your patients, I would imagine, also recognize that if you're not being seen, there's going to be there's room for error there. And but you're saving them the convenience of taking a full day off. And you know what? If this doesn't work and I don't get better, okay, now I will come in.
Correct.
So
Yeah,
yeah,
that's it exactly. And so there are direct primary care practices that do exclusively telemedicine, but in my practice, I do have I just physically opened up a clinic. I was doing telemedicine and home visits previously because that's correct. I mean, in terms of the physical exam that you need, you can't. I mean, yes, there are tools where you can like hear a patient's heart or hear their lungs virtually, but in terms of me, like seeing how the chest is rising, seeing those retractions, hearing all of the things, being in the home to see the physical environment, the beauty of direct primary care to address that concern about liability is that it's relationship based care so that people are they're plugged in with their physician for the long haul in most cases. And so if there's somebody who never calls and you're like, the fact that you're messaging me, I mean, like, for example, I have this 90-something-year-old who, they put their weight in my electronic medical record, and I monitor that. And, when I noticed the weight was going up, I reached out and said, "Hey, didn't know if you are having symptoms." And they said, "Oh, I didn't even realize I was, but I was having some swelling in my legs and whatnot." And so
oh, I didn't know
it's
which direction you were taking that. I saw
yeah,
their weight going up and I was like,
yeah.
Marcus,
So
the
yeah, so
sandwiches, it's the
mhm,
sandwiches again.
yeah.
No, no,
And
no. It was
so
someone with congestive heart failure. Okay,
yeah,
I get it.
exactly. And so in my world, in the world of a direct primary care physician who is, or direct care physician, because again, specialists are choosing this as a model, where you have a smaller panel of patients and are able to monitor them in different ways, whether that be via telemedicine or via in person. You can also proactively say, "Hey, I noticed an issue about you," or "Hey, it's time for your skin cancer screening. Let's go ahead and schedule you," because you're not reactively waiting until like, "Oh, they got seen in the emergency room or they got discharged from the hospital. Now they need to see you within a week." So it's no longer like that. So it's a very different way to address that liability issue, but it's because it's and I pull this quote from Dr. Jake Much, who's in Williamsburg, Virginia, at Defiant DPC, but he calls it small batch medicine. And that I absolutely believe really represents what we do, because it's like if you have even a hint of something is off or you are trying to be proactive about something, you have the time to go after that and not just like let it go. So yeah, that to me, that addresses the concern about liability, which is very, very reasonable and very, you know, we it's a real thing as a physician, especially with me being in California. Yeah.
So how does you touched on it when we were comparing DPC to concierge, but like how does your compensation work? How does your
Mhm.
business model work?
Yep, that's a great question. So, in terms of business model, the business model at a high level, zoomed out view is we are like a Netflix or a gym membership subscription. So, for example, you pay $8.95 or whatever the rate is for Netflix, and you either watch it or you don't. The same thing in direct primary care. So, a patient pays a set rate per member per month, depending on what the doctor sets or what the direct primary care company sets. And then that's what the patient understands is their share per month, and to have, as a result, access to their doctor when they need them. And so that allows us to not have to worry about, well, shucks, I had 5 no-shows and only 2 showed up, and I got 2 99213s today, and that's all I brought home. And it's like, no, we don't have to do that anymore because like I said, I have technically been working today, but I have not been working to see patients in the office because I'm addressing their needs without having to see them in person. And
So that's the
so
only income is from the subscription.
Well, so that is how some people do their direct primary care membership. There's a saying that I absolutely love. If you've seen one DPC, you've seen one DPC. So that's the zoomed out level of membership, which is in most cases the typical direct primary care value proposition to patients. But then other people do, and like I'm one of those people. I charge extra for if there's procedures because lidocaine costs a ton more than it used to. For different procedures, for skin biopsies, for doing skin cancer screening, for doing, non-member services. I do offer because my community it is such a medical desert and it is so in need of basic things like availability for pap smears. Like people can't even get in to see a gynecologist. And there's very few primary care physicians in my area. And so it's like, yeah, if you are at college and you can't afford the time to go to an obstetrician, you can't wait and you need something done, I offer non-member services. So there's different ways to generate an income. And then also in terms of,
But again, you're
depending
not
on,
billing that through insurance. Like you're
so that's
not
a great
billing the
question.
biopsies through insurance, or do you bill them and then they can go after the insurance company for the difference?
Yep, that's a perfect question. And I really appreciate you asking that. So, and that's actually something that I am working to clarify in my own area. So if a patient comes in who's not a member of my practice, but they need something like a pap smear, I will charge them a rate. And so my rate is $50 for me to perform the pap smear. And all the services, it's a transparent price. In terms of what happens with the pathology sample, that is billed to insurance. And so a patient typically when they're like, oh, that's it, I can get it done this day when it's convenient for me, and then you bill the insurance for everything else, like that is a like no brainer in my
50
area.
bucks,
People are
that's the
like, yeah,
copay.
yes, exactly. And so that's how a lot of direct primary care practices who offer non-member services will operate. And then even for members can have the choice whether, like, for example, labs. So transparently, a CBC is less than $5 typically at a national lab service company. And so a patient can be told by their DPC physician, if they're a member, typically, your CBC is either $5 if you go here and you pay directly, or you can use your insurance and magically in the black box, it will be translated to whatever the insurance company wishes to value that CBC at. And so, I've had a lot of patients who chose, oh no, I'll just do the insurance because that's our culture. It's just like charge
Yeah.
that insurance card, just like a credit card. And then magically there's a number at the end, like a flu shot costing $184 for my son one year. And so we learned the hard way, like, well, we're not going to do that again. But for labs, again, going back there, my patients now are like, oh yes, vitamin D not covered by Medicare. I'm going to go ahead with the less than $20 option for that one. Thanks.
Yeah.
So it's, there's different ways to, address that value proposition. But in terms of going back to the question of how do we make our income, there's ways to charge through membership, which is you have X number of members per month paying you on average this amount of money, and that's your take home minus your overhead. Super simple, high level, math there. Yeah.
Okay. How does your patient population differ from your experience with taking insurance to DPC?
Yeah.
Are they more or less educated? Is it higher or lower socioeconomic status? More or less demanding? More or less medically complicated? Or pretty similar?
Yeah. So what I would say is that is exactly, I think, the reason why direct primary care is able to thrive in any community, because the direct primary care physician, their value proposition, no matter how they, how they personalize their DPC to their community, that will attract certain people. So in my practice, 100% of my patients are insured. In terms of my education level, it's all over the board. But in terms of the people who believe in my practice and who have joined, they understand that the nearest urgent care is 30 minutes away and you can't get there on Saturdays and Sundays because then they're not open. And so there's practices who are in, very, very heavily corporatized urban settings, but the availability of having a transparent rate and an affordable rate for a college student or for a parent who has multiple children, the people who join really depends on who understands in that community the value of the direct primary care physicians model. So there are practices where 60% are uninsured. There are practices where 60% are employed, and it's their employer who provides the direct primary care membership for them. It very much differs all over the country. And that's why in every episode that I feature a physician in on the podcast, people can say, oh, that community is just like mine. Wow, I didn't think that it could work in my community because of, I have undocumented members in my practice who, don't have health insurance, or everyone has health insurance and they all have their, I have really good health insurance plans, but yet they can't get into the doctor. So that again, that's the beauty of, if you've seen one DPC, you've seen one DPC, and that definitely impacts the people who understand and believe in the model.
Yeah, I was thinking about the undocumented
Mhm.
population because,
Yep.
right, they're stuck getting it because they can't get insurance. They're like stuck in what seems like an untenable situation
Yeah.
and nowhere to go. And it seems like it would be a great model for them in particular.
And
Oh,
I mean, there's examples like Dr. Wendy Malaska in Wisconsin, Dr. Belena Mott in Michigan. They are taking care of undocumented, people in this country, and there's situations where it's like, well, I ran out of my insulin. How am I supposed to get insulin because I don't have insurance when their patients have come over from different countries? Or, there's people like Dr. Dipti Munkor who takes care of people who for 6 months they're in India, and then when they come back, they need, somebody to take care of them. And that type of service is offered. And then when you talk about just undocumented people, the other thing too is that even if you have, like in California, we have Medi-Cal, not Medicaid, but it's like there's no access. I mean, like, for example, even like in the summer of this year, if you're over 50, no matter who you are in the state of California, you can get access to Medi-Cal. However, it's like, okay, you're over 50, you have Medi-Cal now as a benefit, whether you're documented or undocumented, but you need a rheumatology visit, and the rheumatology visit is 3 hours away. You don't have the gas nor the car to get there. And it's also 6 to 8 months away. So that's your health care because you're 50 and you now are a beneficiary of Medi-Cal. So even with insurance, I pointed this out to a patient, even on the back of the insurance card, it says this card does not guarantee health care because it does not. Insurance is not health care. Care from a physician is healthcare. Care when you actually need it is healthcare, but care because you carry a card that we use like a credit card is not healthcare, unfortunately, in this country.
how did you grow your practice? Like, how did you get the word out for people, right? As you said, people have it in their minds that they just use their insurance card like a credit card. Like, of course,
Yeah.
I'm going to run it through insurance because it has to be run through insurance. Like, how did you start reaching out to people and going, hey, this is a thing. This is the thing that
Mhm.
you will really appreciate if we do this together?
Yeah. That's a great question. So, in terms of how a physician grows, how I grew my practice, one thing I will say is that no matter where you are in the states, you definitely have to be aware of non-compete and enforceable non-compete laws in your state. So, for example, in New York, there might be a different non-compete than there is in California. In California, they're non-enforceable. So that impacts how a patient can learn about direct primary care from their physician, if their physician is going to be going into direct primary care. So that is something for especially those early on in training, medical students, residents to keep in mind if they can negotiate out of their contract non-competes, or if they're in a state that's not enforceable, or that where a non-compete is not enforceable, it's null and void, doesn't matter. In terms of when a patient is learning about direct primary care and is attracted to and then joins a direct primary care practice, that's going to differ depending on the patient and the location and the offering of the DPC physician. But in terms of typically what happens is there's usually this threshold of a direct primary care physician will either open, like Dr. Kissy Blackwell in Wichita Falls, Texas, who
How
opened
do you
with
remember all these
200
people's names? You've name dropped so many people from all of your episodes. Like, I can't keep a person's name in my head for more than 30 seconds. And you remember everybody's first and last name and pronounce it impeccably, I think.
This is
You could also be making all these people up. Are you making all these people up?
I definitely am not doing the latter, but this is how much each one of those people is really impacting healthcare in America, right? It's like they mean so much to me because they are doing this basic healthcare right for, I mean, that they're doing, but they're providing this basic human right, is what I meant to say, to people in their communities and making such a difference every day. And for a primary care physician, it just makes me so happy that I am able to be in the space with these people. So that's, for me, that's how I remember not only their names, but their stories. And so she opened, Dr. Kissy Blackwell, with 278 people on her waiting list before she opened her doors. And then there's people like myself, I opened with 0 and grew from there. But in terms of how people grow, usually there is this threshold of word of mouth, and around 50 patients, 100 patients, then everyone's like, oh, everyone's telling other people about, oh yeah, I just texted my doctor, no big, like, sorry, you had to go to urgent care for, a strep swab when you could have done that for like $15 or something, or included in your membership. And then people start becoming the value proposition and the advertisement for your practice. And so it really allows, again, it allows that autonomy from a physician, but then it allows the physician to just do what they need to do. Now, there are markets like the direct care physicians in Pittsburgh. It's a group of people who are physicians. Currently, they're all females. Where they each have their own practices, but together they're collaborating to have a marketing campaign to be seen and heard above the offerings that are corporate in Pittsburgh. But in terms of, that word of mouth, that is typically how a direct primary care practice will grow. And then how to get that word of mouth going, people do it all different ways. They go to BNI meetings, they go to Chamber of Commerce meetings. They just, go into the local subway and tell the owner, hey, like, if you're looking for healthcare, I'm open. In terms of my practice, I was very fortunate because I practiced for almost 6 years in my neighborhood. And so being again in a medical desert, my patients who joined immediately, it was very humbling because my patients, all who joined in the first year, were just like, I can't lose you. Like I have very much, valued our relationship as a physician patient, and I can't lose that because there is nothing else like this up here. And that was when I was in fee for service, which makes me so happy that they understood that this is even better than that at my private practice. Yeah.
Have you had any proceduralists that you've encountered, like surgeons? Like you mentioned the orthopedic surgeon, right? And you said not direct primary care, but direct care.
Uh-huh.
So I know it's not in your practice per se, but what about some of these like higher cost procedures,
Yeah.
right? Do you know how any of that works?
Yeah, that's a great question and so needed. So the first example I love to say is that, a family practice doctor, primary care doctor can be doing procedures left and right because, that might be within our wheelhouse and our training. So for example, circumcisions, biopsies, colposcopies, those types of things, even deliveries, like people in C-sections, people in primary care do those things still. When it comes to specialists who are doing procedures, I like to highlight options like the Surgery Center of Oklahoma and the Wellbridge Surgical Center in Indiana. Those are places where literally you can go on the website and say, I need a colonoscopy or whatever it is, and you can get an estimate as to this is how much it costs. So when a person is open to, okay, my plane ticket on Southwest plus the hotel on hotels.com plus the surgery is still less than what I would have paid through using my insurance benefit, and I have the time to take off of work, well, I'm going to do that. Sure. So there are places where physicians are getting together and collaborating to say, yes, together as specialists, we can offer a whole surgical center, even as an option. So different types of surgeries happen at those surgical centers. People who are doing things like neurology, endocrinology, rheumatology, dermatology, let's see, what else? Gastroenterology. There's so many examples of where people are saying, okay, this portion of my practice, I can have either an insurance rate or a cash rate, or they're just saying, no, I just do all cash. And so that really depends on how a person is, using their skills in specialty care and where their patients are able to get access. If they are finding that a cash price is what allows them to fill their practice, then they'll do that. If they're finding that, because there are some hybrids out there that a patient will want to use their insurance for services, they can be apart from a corporate location, but still offer insurance-based care. I forgot to mention cardiology. That's also a big one where people are doing, all outpatient cardiology, workups, visits, all of that stuff, because there's no accessibility and they're just paying cash. So there's so many options, and the options are out there for any specialty. I mean, even vascular surgery. I was talking to somebody who's a dear friend, and they were saying, even if I just did the ultrasound review for people, just that portion I could be charging a cash rate for and have, a very quick turnaround versus if they had to see me in the office. And because that person is, licensed in a state rather than a county, that service could be helpful for people all over the state that they live in. So there's so many options. And this is where I really appreciate like you asking these questions, because again, your audience is the same type of people that we went to medical school with. And it's like, we didn't learn that this was an option in medical school and residency. It was just, this is your chart. Now you code it and then you go to work for a coding employer. That's the typical pathway that we take as physicians, especially in primary care these days.
Well, and for that vascular surgeon doing the ultrasounds, in a large state, or
Mhm.
maybe even not in a large state, your health insurance is local. You can really only take care of, like, if you're reading ultrasounds for people that live far away, like I'm on Long Island. I don't have any contracts in Buffalo, but I'm licensed in New York State. So really
Mhm.
the entire state now becomes my catchment area in that situation. So
Correct.
really, it could work. It could work. Um, so you're available to your patients 24/7.
Mhm. Yeah.
So how do things like vacation and getting drunk work?
Well, so I definitely am not a ladder. In the latter group often. I don't think I've ever been drunk technically because I will sniff alcohol. It's so funny. I was with a group of physicians doing a direct primary care, themed retreat, and I sniffed the wine that they had at their wine tasting, and my eyes shut and I was talking like a sloth. So I don't do alcohol. But in terms of the 24/7 and vacation and just, the idea of not creating another burnout situation, the beauty of direct primary care is that because it's a relationship-based practice, patients for the majority of the time, and this is all over the nation because I often ask this question of my own guests, is that the patients do not have the anxiety of, oh my gosh, I'm not going to get in for 6 months. So I have to ask all the questions right now, or I have to ask after hours because that's when I remembered. And it's like, no, you actually have access to your doctor when you need them. So they are very mindful and respectful most of the time, that it's like, my doctor, we got to take care of our doctor so that they can take care of us. So they typically will, like Dr. Julie Gunther in Idaho, I mean, they're cheering her on if she needs to take vacation. My patients were like, "Oh my goodness, I'm so excited you get to go to Legoland," because we were gone in Legoland in August with my now 5-year-old and now 2-year-old. But they're very supportive. And then after hours in my practice, which has been open a little over a year, I've gotten 3 calls after hours. One was for a cardiac concern. Two were for cardiac concerns. And the third one was for something that was non-acute. But what we tell our patients is, if you don't know if you're going to go to the ER or stay home, that's a great way. It's a great time to contact your doctor. If you're like, I'm having a cardiac arrest, we're not, some people do hospital medicine, but typically, the verbiage to patients is, if it's a medical emergency, dial 911, like it is on any medical, reception line or message machine. And the same thing holds for direct primary care, but if a patient is seeking guidance as to, is this acute or not, to the point where I need to drive 45 minutes to the emergency room, that's a great time to ask, your physician. But that doesn't happen, thankfully, too often. And then even in things like COVID, we saw direct primary care thrive as a movement because there wasn't the limitation in the, spring about, oh, there's no coverage for telemedicine services. Direct primary care has always incorporated telemedicine. And so we kept, as a movement, we kept so many people out of the hospitals because we were able to say, here's the pulse ox. It's like $16. Go ahead and here you can buy it, check it out, whatever. And we're going to help watch you over telemedicine if we need to see you in person, whatever. But they kept people out of the hospital for COVID, not to mention, like I mentioned, the CHF example, but there's so many things because it's a longevity relationship and not just periodically every few months you get seen, that it's so powerful to have access. And that's where patients don't typically abuse the 24/7 aspect, because they can reach their doctor the next day if they needed to. Yeah.
But have you had any patients or even heard about patients from other DPC physicians that, because some patients don't understand boundaries. Like, it's
Oh
not
yeah.
even that
Yeah.
they're pushing the boundaries.
Mhm.
It's that it's just something that they just don't understand. And you can often see that when you're interacting with them.
Oh yeah. And especially in fee for service, because too many times it was like, and I have my list of 52 items that I'd like to cover in my 8-minute visit with you. And it was like the boundaries there. That was an exercise for me in boundaries. When I look at direct primary care models all over the nation, yes, boundaries are absolutely something that a physician has to address, whether that be, boundaries where they're the number of hours that they're checking messages or how they're checking messages. But when it comes to patients who are quote unquote high utilizers, that's what we typically call a patient who is really not respecting the boundaries set forth by the practice. A physician, we are, as direct primary care and direct care physicians, we have chosen a different path than the typical going into employed medicine. And so with that, we have an air about us in terms of, we value ourselves. And so when it comes to patients who are, you know, making us feel uncomfortable, stressed out, overworked, all of those things. When we have a community where direct primary care physicians, I mean, if you go into a room of them, it's like, what Kool-Aid did people just drink? Because this is crazy. Like, everyone's so happy. And the way that people protect that is, one, seeking support from other people and saying, hey, how do you manage this situation? If a patient will, like, if they're a night shift worker on the OB floor and they text at 2:30 in the morning and they don't understand that, like, that dings your phone, then, typically the recommendation for most of us would be, yeah, and you got to talk to that patient and say, hey, I am a single show here, or I'm, taking care of so many patients.
Yeah. So you
Um,
draw that boundary, but then Have you been in a circumstance or have you heard from one of your colleagues where they've had to let a patient go?
Oh,
Right?
absolutely.
Like,
Yeah,
okay. So
absolutely. There
that's another okay. So it's
Mhm,
like it's not like you've paid your money and now you can do whatever you want. No,
correct.
it's I'm going to warn you, and then clearly we've had this conversation. If we have to have it one more time,
Mhm,
you're off
yep,
the panel. I'm
yep,
sorry, it's just
and
not working.
yes, and people protect that in their patient contracts when they sign a membership saying that, if these things happen, if abusive language is happening, if, if whatever the physician sets forth is being done and you've had a warning, then this is not going to be the best fit for you. There are some physicians who, and they've shared this on the podcast, they'll say things like, all right. And so going over the patient contract before you sign on to my practice, you need to understand I have 2 children and I go to bed at 7:30. And so if you contact me, you better have a darn good reason for contacting me after hours. And that's how, this is how one physician, she manages her patient onboarding um at the beginning of her practice before the members sign on, because she's saying right from the beginning, this is my practice and this is how I run my practice. If you cannot respect that, you cannot be part of my practice. And so that is very common how people are setting those boundaries. Yeah.
Fantastic, fantastic.
Mhm.
So where can people find you? Let's say we have a listener who wants to be on your panel, or they want to listen to your podcast. They want to connect with you on social media. Where do we find you?
Yeah, so great question. So the most common things would be with the at my DPC story handles. So Instagram, it's at the I guess generally mydpcstory.com would be the branching point as to where to hear physicians from all over the country. I have a mapper where people can click on their area and listen to episodes in that region. I also have a resource page where people can download completely free, checklists as to how to open your direct primary care practice from nothing. And then on the bottom of my website, I have all of the social handles. So just at my DPC story or at my DPC story would be where all of the social media lives on any platform pretty much. But mydpcstory.com is probably the best place to start out. And then if people are podcasters, on all major podcast platforms, you can find My DPC Story, the podcast.
Fantastic, fantastic. Well, it's really exciting stuff that you're doing, and clearly you're an evangelist for it. Um, and thanks for all the work you're doing for your patients and for medicine.
Absolutely. Thank you so much for having me and for helping spread the word about direct primary care.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.